do not realize that there are experts that can make up their personal health care team to help you all live life to the fullest. Both people living with Parkinson's and your loved ones face a variety of challenges in the activities of daily living. Learning to live well with Parkinson's requires support from family, friends, and an integrated health team of healthcare professionals who focus on both pharmaceutical as well as other interventions such as speech therapy, physical therapy, emotional support, etc. It is my privilege and pleasure to introduce you to an interdisciplinary team of professionals from the Jeff and Diane Ross Movement Disorder Clinic at Baycrest Center, who are here tonight to share their expertise on different aspects of how to get the most out of your journey. The director of the clinic is Dr. Kleiner Fisman, who I first met 4 years ago, when tonight's activities were just a dream. She wanted desperately to put together a team of caring experts, and now has realized that wonderful dream. Circumstances in both her personal and professional life have resulted in Galit's belief that it is possible to enable and empower people with Parkinson's to be the best they can be, and to live to their full potential through the journey by providing practical solutions for everyday challenges. Galit will expand on that, I'm sure. Dr. Galit Kleiner Fisman finished medical school at McGill University in 1996. She did her interval medicine and neurology residencies at Brown University in Rhode Island, Leahy Clinic, and Harvard University in Boston, Massachusetts. In 2001, she returned to Canada, where she completed a clinical research fellowship in movement disorders with Dr. Tony Lang at the Toronto Western Hospital. Following completion of her training in 2003, she moved to the University of Pennsylvania in Philadelphia, where she was the clinical director of the Parkinson's Education Research and Clinical Center, a multidisciplinary center for American veterans with Parkinson's disease. In 2006, Dr. Kleiner Fisman returned to the University of Toronto and worked at Toronto Western and Baycrest, caring for people with Parkinson's. In January 2012, thanks to the generosity of Jeff and Diane Maverick Ross, Dr. Kleiner Fisman and Mrs. Pearl Greif of the Assistive Technology Clinic joined forces along with the Baycrest Center for Geriatric Care. The people who made this clinic possible are here this evening, but I'm not going to point them out. What I would like you to do is just take a minute and turn to whoever's sitting beside you or behind you and just say thank you, because I think they deserve it. Please just do that for a minute. Just say thank you. That way I know they'll get some thanks. Okay, that's enough. It's not about you anymore. Okay, got that. That way I was hoping to ensure that they got some, because donors are everything. Our donors are magic and everything to us, and I know they're very important for the Baycrest Center. So this innovative interdisciplinary clinic that provides optimal care for people with Parkinson's is directed, as I said, by Dr. Kleiner Fisman. And in her spare time, guess what? She's the wife and busy mother of 3 little ones. Whenever she has spare time, and I don't know how she pulls it off, but she does. Anyway, please give a very warm welcome to this wonderful team.
It's a real privilege for myself and for my team to be here to talk to you about our passion, what we do every day, which is provide care for people living with Parkinson's disease. We work with people with Parkinson's to deliver complete, coordinated care throughout the continuum of symptoms. Our philosophy is that people need accurate information and they need support in all aspects of their lives, and that's what we try to deliver. When I started working at Baycrest in 2008, I began a geriatric movement disorder clinic for people with Parkinson's disease, but I was very frustrated because I was solo, I was working alone, and I found it increasingly difficult to provide people with all the services that I knew that if they had, they'd be able to really live well with Parkinson's. My husband, who does infectious diseases, calls it the infectious disease model of care, which is you have a problem, you see a doctor once, you get a couple of pills, and you go home, and that's the end of it. But we all know that in Parkinson's it's not that simple. It's not enough to see a doctor a couple of times, it's not enough to get a couple of pills. It becomes a much more complicated problem. However, for many people with Parkinson's, this is how their condition is managed. And so we decided that for a person to thrive, we wanted to offer them more. We wanted to offer coordinated and ongoing support from numerous healthcare professionals. So tonight's presentation is going to outline how we do this at our center. So you're going to hear from various members of our team, starting with me. I'm a movement disorders neurologist, as Sandy has discussed. You're going to hear from other members of the team, including a physiotherapist, occupational therapist, dietitian, speech and language pathologist, pharmacist, clinical health psychologist, and our clinical administrator, who has a very important role as being the frontline person of coordinating everything and communicating between all of us and between all of you, the people that we serve. Each person will do a brief presentation on what kind of problems their area of expertise addresses. The presentations intentionally will be brief, and we won't be able to cover everything that we do, but we hope we'll be able to at least give you a flavor of how we approach problems. So before I get into exactly what we do at our clinic, I want to first highlight what the burden of Parkinson's is on individuals, their families, and on society. And then I'm going to outline why I think currently the solo doctor approach to Parkinson's doesn't really work. And then I'll discuss what it is that we do at the Jeff and Diane Ross Movement Disorder Center that's different, and hopefully you'll agree better. So Parkinson's disease is the second most common neurodegenerative condition, only after Alzheimer's disease. About 100,000 people in Canada are currently living with Parkinson's disease, and it's actually estimated that as the population ages, that number is going to increase, with a quarter of people over the age of 80 living with Parkinson's. While people initially benefit from medication that replaces dopamine, the neurotransmitter in the brain that is one of the communicators that is depleted in Parkinson's, after many years of having Parkinson's, there's other symptoms that may emerge, symptoms that are not necessarily related to movement, and symptoms that don't necessarily improve with dopamine replacement. Problems such as thinking difficulties, falls, excessive daytime sleepiness, hallucinations, depression, urinary issues, problems talking. These are all serious problems that can significantly reduce the quality of a person with Parkinson's life. But as many of you know, when you go see a doctor, the focus is primarily on medication adjustments for movement symptoms. There's little discussion about other strategies for symptoms that may not respond to medications. Not only are there not really much in the way of discussion or recognition of these symptoms, there's not much in the way of offering treatments for these symptoms. Well, people aren't defined just by Parkinson's. There's other factors in their life that affect their health and their ability to apply recommendations from their doctors. Doctors have to take into account all the complexities that make up a person's life, from their physical and emotional health, to their relationships and other support systems, and to their financial situations. So given the fact that I've just told you that Parkinson's is an extremely complex condition, as you all know, you'd think that people with Parkinson's would then all go see Parkinson's specialists and have access to the best care possible. There was a study actually done in Ontario looking at healthcare utilization, and I was very surprised when I read the study to find out that only about 50% of people with Parkinson's have access to a general neurologist. This is for people under 65. It drops to only a third of people over the age of 65 that have access to a neurologist, and that's nothing to be said about movement disorder specialists. We don't actually have statistics related to that, but as you all probably know, there's a big difference between having general knowledge in neurology versus the specialized knowledge associated with all the complex systems of Parkinson's. And so many people are left to have their symptoms managed by family doctors that are often overwhelmed by the complex symptoms related to Parkinson's. So in terms of what the current system doesn't emphasize, it doesn't emphasize education. There's little emphasis on teaching people what they need to know about Parkinson's, including understanding their symptoms and how to maximize the effects of treatments, including strategies other than drugs. Additionally, even if people somehow know about other strategies to managing symptoms, there's limited access to skilled professionals like physical therapists that are knowledgeable about Parkinson's. Physical therapy, for the most part, is not covered by OHIP, so often only people with private insurance have access to this. Another major oversight is lack of consideration of what impact there is on the person with Parkinson's and the whole family unit if caregivers are stressed and overburdened. The caregiver is part of the unit and needs to be considered in the equation. So the consequences of ignoring these important strategies, such as education and other strategies to managing the condition aside from medication, are real and concrete. By taking medications inconsistently or the wrong way due to lack of knowledge, bad reactions to medications may occur, or symptoms may be poorly controlled, and people suffer unnecessarily. By not providing alternative strategies to deal with drug-resistant symptoms like poor balance, people are more prone to falling. So I'm going to put up a kind of a scary slide. And these are some statistics regarding what the consequences are of not educating people and not offering them other strategies. This study was also done by the same group. It was Mark Gutman and his team, looking at healthcare utilization in people with Parkinson's. And what they found was that, this is specifically in Ontario, admission to hospital occurred 40% more in people with Parkinson's compared to those that didn't have Parkinson's. And once people with Parkinson's were admitted to the hospital, they stayed there 20% longer. Further, people with Parkinson's have a 5-time higher likelihood of living in a nursing home compared to people of the same age that don't have Parkinson's. And then once in the nursing home, the costs associated with their being there are 5 times higher compared to those without Parkinson's. So I think those are fairly staggering statistics. I put them up in order to emphasize what a big problem we have, and the fact that this is unacceptable, and the fact that it doesn't have to be this way, because if only we use the available strategies, then we can actually reduce disability, and we can reduce this kind of suffering and what occurs downstream. So hopefully I've made now a convincing argument that thus far there is good reason to reconsider how we as healthcare providers are caring for our clients with Parkinson's. I'm now going to describe what we do at the Jeff and Diane Ross Movement Disorder Clinic, which, as Sandy said, is a partnership between the Assistive Technology Clinic and Baycrest Geriatric Center. So given that right now the reality is that treatments for Parkinson's are aimed at controlling symptoms and not at reversing or preventing progression of the disease of Parkinson's, the question is, how do we maximize treatments that are already proven and available to reduce disability and improve quality of life? So I'm going to now sort of describe to you the process that we have put together, that we have sort of trial and errored, and I think are now getting to a point that this is a pretty good system. It starts with a very thorough assessment, a medical assessment where you spend about 2 or 3 hours with me, for better or for worse. But subsequently, we come up with an individualized medication schedule that suits your needs, that suits your lifestyle, that suits your goals, takes into account other medical conditions, and all the various factors that go into your life. We try and identify early issues such as non-movement related symptoms like urinary issues, sleep problems, psychiatric problems, and we refer to subspecialists. I have a whole network of people here in the GTA that specialize in the problems of sleep in Parkinson's disease, and the problems of mood disorders in Parkinson's disease, in the urological problems of Parkinson's disease. There's no reason why people should be living with these symptoms without having them addressed, because I think they do a lot to contribute to suffering and quality of life. In the context of this evaluation, I'm also able to identify what people know and what they still need to know. And so subsequently, people are invited back to our clinic a few weeks later. At that point, they have a chance to meet this wonderful team, and I'll talk about that more in a moment. We do a follow-up with regards to the medication that we have prescribed to ensure that things are going smoothly and that there's no problems. And if there are, we make modifications. And subsequently, after this group assessment, we offer various individualized programs, and I'll tell a little bit more about that in a minute. So that session that people come back for is both an education session as well as a screening assessment by our allied health team. The core assessment is done by a physical therapist, occupational therapist, dietitian, and pharmacist. And according to their assessment, we decide if other specialists need to get involved, such as a speech-language pathologist, a clinical health psychologist, and other programs that we have at the Assistive Technology Clinic. So this is kind of a diagram that talks about the numerous programs that the person with Parkinson's has access to and provides services. But the assistive technology provides services not just to people with movement disorders, but with various neurological conditions. This includes those with multiple sclerosis, stroke, ALS, movement disorders, and any other neurological diagnosis. Our combined center approach makes sense from a resource point of view, as already present infrastructure has been able to absorb this new movement disorder program. While causes for neurologic impairment differ and therefore pharmacological therapies differ, the problems of immobility, limitations in activities of daily living, communication, and psychosocial problems as a result of coping and living with a chronic disease are common across many conditions. So, in addition to the education that we hopefully provide on the ground, we also have a complementary website that we're about to launch this week that we're very proud of and we've been working on for a long time with the contribution of the entire team of the Movement Disorder Clinic. And this will hopefully be launched next week, and it's going to be called Live Well with Parkinson's. You can link to it through the Assistive Technology Clinic website, and I'm proud and happy to say that the Parkinson's Society of Canada, Parkinson's Society of Canada, Central and Northern branch has agreed to endorse the website and also link through their website. So hopefully you'll have complementary information that you may need and hopefully will find useful. This clinic is really a unique and wonderful collaboration between the various centers, the Assistive Technology Clinic and the Baycrest Center for Geriatric Care. We're very lucky today, as Sandy said, to have in our audience Jeffrey Ross and Diane Mavernack Ross, and I just want to take a minute to formally thank them because really without their vision to have this opportunity to actualize what we perceive as really the best programs for people with Parkinson's, this couldn't have been possible. It's important to understand that a lot of these programs aren't funded by OHIP, and therefore people don't have access. And we felt it was important that everybody have equal access, and thanks to their generosity, we're able to do that. In fact, our patients have given us feedback that this approach is the kind of care they perceive should be the standard of care, and hopefully this will catch on around the country. So thank you very much, everyone. Given the fact that there are so many of us talking tonight, we're each going to take the opportunity to introduce the next person. So I'm now going to introduce Orla Hares. Many of you know her. She's a registered physiotherapist. She's originally from Ireland. She trained and graduated from the University of Brighton in the United Kingdom in 2003. She's worked both in London, the United Kingdom, as well as Dublin in Ireland, specializing in neurorehabilitation and movement disorders. Orla brought her international experience to Canada in 2011, has been a valuable member of the assistive technology team ever since. She's a very enthusiastic physical therapist, both clinically and academically. And through her assessment and treatment with boundless enthusiasm, Orla works to improve movement difficulties using an individual's personal goals to help motivate them and to get good results. So Orla?
Thank you, Galit. Hello, everyone. They're falling asleep on me. So, as I was introduced, my name is Orla, and I am the physiotherapist, and I'm going to briefly just give you a snapshot of what the role of the physiotherapist actually entails. So, basically, we look at the assessment, we look at caregiver advice and treatments. Within the assessment, we look at posture, we look at the ability to get up from a chair, we look at your risk of falls, which includes your balance and your walking. So posture-wise, why do we look at posture? Well, posture can cause a lot of pain and discomfort. It can prevent you from reaching overhead, and in a roundabout way, it can actually prevent you from walking really well. So, just briefly, that's posture. We also look at the ability to get up off a chair. Some people don't realize how hard it is to get up off a chair, particularly if they've been sitting for a while. This can prevent somebody from walking to the bathroom or being able to walk to the kitchen for a drink of water for themselves. In the clinic, we work on this and we give you techniques to make this task so much easier, thereby allowing you to keep your independence. Now, we also look at the risk of falls. I don't get anybody to do anything as energetic as this, but I do look at your balance, and I do look at your walking. So, as Dr. Kleiner Fisman actually mentioned earlier, people with Parkinson's are more likely to be admitted to hospital. If you're admitted to hospital, you can actually stay longer. So I look at these risks, and we try to eliminate them to make you safer and independent. And I usually ask questions like, for balance, do you hold onto the walls at home? Do you hold onto the furniture? Do you prefer to use a trolley in the supermarket, and do you feel a lot more confident doing that? Have you had any near misses, or have you had a fall already? Do you think that you need a walking aid to actually make you safe? Walking-wise, I look at different times of the day because you may have some off periods, so your walking is different during those times. Do you actually have any freezing? Do your feet get stuck to the floor? Do you hesitate crossing the street or going through doorways? Do you have problems turning, particularly in tight spots? Basically, we aim to try and keep you as independent as possible, and we work on all of these, giving you cues to actually help you to stay independent, and then that you're not going to have any risk of falls. Caregivers, we also actually look at caregivers because you are an extremely important person and you are part of the team. We work on cues, we work on your transfer techniques, we give you equipment advice, and we also just provide an ear for you so that you can actually list your difficulties, and if we can help, we will. So treatment-wise, what does this all actually mean? Well, at our clinic, we strive to work together to keep you well and independent. We are able to assess you in the clinic and identify issues before they become a major problem. And then thanks to the generosity of Jeff and Diane Ross, I can bring you back for a follow-up appointment with me. It's a one-to-one session where we can address these issues in more detail. Generally, this means I can give you an individualized, personalized program that you can work on by yourself and improve on them. And then I can bring you back for a follow-up again to make sure that you've actually followed through with the advice and that that advice is working for you. If it's not, the Assistive Technology Clinic actually has some rehab programs which are available. Again, these are one-to-one programs. It's, again, working on all of your issues in a lot more detail. We work on your goals and reduce your risk of falls. We also have poling classes. Now, pole walking is a new thing that's kind of coming into Toronto. You may have seen a lot of people doing it already. It is shown to actually be very effective for posture. It improves your fitness level. It also improves your confidence. If your confidence is up, your risk of falls is actually a lot less. And you're more likely to want to walk outdoors, and it's also very social. So remember, no matter what stage you are at your Parkinson's, we do help, and we can give you the tools and the ability to keep your independence and fitness for longer. Okay, well that's me in a very quick snapshot. Now I have the pleasure of introducing Karen. Karen Hall is our occupational therapist and clinical manager of the Assistive Technology Clinic. She is a graduate of Memorial University of Newfoundland and received a Master's of Science in Occupational Therapy from University of Toronto. She is an Assistive Devices Program Authorizer for Seating and Mobility and for Augmentative and Alternative Communication. Her research on power mobility driving training is published in the journal Assistive Technology, and Karen has presented at the University of Toronto and various conferences on ALS management, AAC, and seating and mobility.
Hi, everyone. Hello. Getting some good enthusiasm. It's great. People with Parkinson's may face challenges, in a number of areas, including their activities of daily living, within their home environment, with mobility, with written communication, which includes handwriting and using the computer, or accessing community resources. Occupational therapy can provide strategies for dealing with these challenges, often through assistive devices. These strategies can help people with Parkinson's to maintain independence, ensure safety, and improve quality of life. Hand tremors and stiffness can make activities of daily living, like eating, dressing, or grooming, more difficult. Assistive devices can help. For example, wide-gripped utensils can make eating easier if you have difficulty with grasping. Zipper pulls can help if you have issues with hand function. You can also try wearing clothes with less buttons or zips, or looser fitting clothing. And if you have trouble brushing your teeth, for example, electric toothbrushes can help. One of the most common problems I get asked about is moving in bed due to stiffness. You can try using satin sheets or pajamas, as cotton and flannel actually make it harder to move in bed. Try lightweight blankets, which don't weigh you down. You can use strategies to ease rolling in bed, for example, bending at the knees first. You can also try using a bed rail. A bed rail can help you in turning in bed, but it can also help to assist you in getting in and out of bed. Stiffness and balance problems can make it difficult to climb up and down stairs or to stand up. Stair railings can make stair climbing safer, and lift chairs can safely assist you to sit and to stand. Lift chairs also have the added bonus of reclining, which can counteract stoop postures when you're sitting and relaxing. Equipment in the bathroom can make it easier to get on or off the toilet or take a shower or bath. And this equipment can also prevent falls and ensure safety in an area of your home where falls can happen. When walking and balance are limited, you may need a mobility device, like a walker, a manual wheelchair, a scooter, or a power wheelchair. These mobility devices can allow you continued independence and safety to outings and activities that are important to you. The Government of Ontario can cover up to 75% the cost of these mobility devices through their Assistive Devices Program, or ADP. And as an authorizer for ADP, I can find the right device that suits your needs. If handwriting is difficult, adaptive pens can help. You can also be assessed for computer options like on-screen keyboards or mouse options if keyboarding or using the mouse is difficult. Our team at the Assistive Technology can find the right devices to meet your needs. And there is funding available through the Government of Ontario, their Assistive Devices program, for these computer options. And we can also discuss free options that are available. For example, in Windows accessibility, there are features that help if you have hand tremors. If you need help in your home, we can refer you to Community Care Access Centers, or CCAC. For an example, we can refer an occupational therapist to go into your home to do a full home safety assessment. We can also refer you to a personal support worker, for example, if you require assistance in your home with bathing or dressing. Living life to the fullest with Parkinson's includes staying involved in your community and engaging in activities that are important to you. We can help find you activities at local community centers or seniors' day programs, for example, that suit your needs and preferences. And the Parkinson's Society of Canada also works with the regional offices in your community to provide education and social support within your home community. Thank you very much for listening to my portion of the evening. It's now my pleasure to introduce Nicole Shuckett. Nicole has been a registered dietitian for 17 years. She received a Bachelor's of Human Ecology from the University of Manitoba and a Master's of Science in Nutrition from Case Western Reserve University. Nicole worked at Baycrest for 12 years. She currently works at the Assistive Technology Clinic in the ALS Clinic, the North and East GTA Regional Stroke Best Practice Team, and the Jeff and Diane Ross Movement Disorders Clinic. She has given many talks on the nutritional issues of ALS, stroke, and swallowing disorders. Welcome, Nicole.
Hi, everyone. Hi. You guys keep being alert. Great. When I assess the people in our clinic, the main issues that I'm looking at as a dietitian is the diet or food intake people are doing, weight change, constipation, nausea, poor appetite, chewing and swallowing difficulties that Anna will address in a few moments, and other issues that are affecting a person's ability to maintain a healthy weight and good intake. My goal is to make sure a person with Parkinson's meets all their nutrient needs and help them find solutions to any nutrition-related symptoms they have. This is just a small list of some of the symptoms that people experience, and my goal is to make sure we cover all of them and look at all of them individually. I also am looking at the times people are taking L-DOPA and eating food. The first thing I do is assess a person's eating habits or their food intake. How are you eating? And are you eating enough food to meet your individual nutrient needs? We really try to make sure everyone is looked at as an individual in our clinic, so we make sure that I'm looking at everyone minutely. Maintaining a balanced diet is very important for all of us, but it is particularly true and important for people with Parkinson's. A healthy diet can give you a stronger immune system, more energy, and help you feel healthier. You have energy to do the things you want and need to do, and have building material for your body to grow, renew, and repair itself, and support the immune system to fight off infections. I'm also often asked in the clinic, is there a special diet I need to be following now that I have Parkinson's? And the answer is actually no. The most important thing you need to make sure you are doing is eating a well-balanced, healthy diet. A diet that includes foods from all the food groups. Meat alternatives like poultry and fish, milk and alternatives like cheese and milk, grain products such as bread and rice, and vegetables and fruit like spinach and berries. You need to be eating a variety of nutrient-dense foods, and I always say the more colorful, the better the food. One of the most common symptoms that people experience is maintaining a healthy weight. And I'm always strategizing with clients to ensure they're maintaining their healthy weight, as it is one of the most common problems that people experience. Weight loss is often a very huge issue that people experience. It's often caused by tremors or involuntary movement because as your body is doing this, you're using up more calories, so you have to be eating more to make sure you don't lose weight. Also, you may be experiencing swallowing problems, nausea, or poor appetite, and all of these things can lead to weight loss. My role is to help provide strategies to help maintain your current weight and stop further weight loss. There are people who also gain weight when they have Parkinson's. This may be due to a decrease in exercise or lack of movement and change in eating habits. I just want to remember for everyone, if you want to try and lose weight when you have Parkinson's, you should always make sure you're being followed by a dietitian because we never want to let anybody lose too much weight when they have Parkinson's. Another thing that I'm often dealing with, as most of us are in our team, is to help people control their constipation. Many people with Parkinson's suffer from constipation and want to manage it more effectively. Constipation is a result of slowing of bowel muscles that cause stool to pass more slowly. A person with Parkinson's often has difficulty having a bowel movement. Different medications can help, but also eating healthy can even help even more. Eating foods high in fiber, such as fruits and vegetables, whole grain bread, and bran cereals are great choices. Eating this way makes it easier and softer for the stool to move through the bowel. If you suffer from and are not used to eating fiber, don't all of a sudden start eating a lot of fiber at once because the results won't be very good. You should always increase the amount of fiber in your diet very slowly. Drinking fluids is also very important, and I'm often constantly saying 6 to 8 glasses of fluids a day. Everyone says to me, really, that much? Yes, that much really helps the bowels work effectively in the body. Fluids help the body use fiber and prevent bloating and gas. Another really important part of constipation management is exercise. And exercise will help keep your bowels regular also. If dietary changes are not enough to improve constipation, you need to talk to your physician or your pharmacist about medications that may be needed to help with constipation. I'm also often providing strategies to help people improve symptoms as a result of decreased nausea and improve their appetite. Not all people with Parkinson's experience nausea and poor appetite. Parkinson's itself is not commonly causing the nausea or poor appetite. It is often the side effect of the medications taken to treat symptoms of Parkinson's. It can lead to weight loss and decline in daily functions. Strategies such as sucking on ginger or taking your medication with ginger ale and soda crackers sometimes can help. You should always talk to your physician if these symptoms are really impacting your life, so we can work on strategies together as a team to help you control these symptoms. Now, not all people are aware of this, but there is a really special relationship between protein and L-DOPA, one of the most common medications that people with Parkinson's take. Protein is found in meats, fish, poultry, nuts, legumes and dairy products, and a wide variety of other foods. In some people, the L-DOPA will not work properly if protein is eaten at the same time. This is because there's a competition going on in your body. The protein and L-DOPA in your body are both competing with this and require the same receptor to be absorbed into the body. In this competition, protein always wins. If protein in your stomach is eaten at the same time as L-DOPA, the L-DOPA does not get absorbed as well and it doesn't control your symptoms as well. It's like you never even took the L-DOPA. That is why we're always stressing to you to take your L-DOPA on an empty stomach or with ginger ale and soda crackers. And if some of you have been to our clinic, you know our infamous diagram. So when you take your L-DOPA and eat protein, you want to take your L-DOPA 30 minutes before you eat protein and take your next dose of L-DOPA at least 2 hours after your last protein meal. And finally, always remember that this is just a guide to help you understand, and that every person is an individual and has individual needs. And to make sure we always set up an individualized plan with the doctor and myself that works best for your lifestyle and best to control your symptoms. And that's all the dietitian has to say. speech-language pathologist at the Assistive Technology Clinic for the Northeast and GTA Regional Stroke Best Practice Team and the Jeff and Diane Ross Movement Disorders Clinic. She is a graduate of the University of Toronto and received a Master's of Health Science in Speech-Language Pathology from the University of Toronto. She is an authorizer of the Ontario Ministry of Health and Long-Term Care Assistive Devices Program in Augmentative and Alternative Communication. She is a Lee Silverman Voice Therapy Certified Clinician who incorporates her training into her practice. Anna.
Hello, everyone. So I was the one listening very, very carefully to you all when you first said hi to Sandy, and I'll talk about that a little bit more. So the easy way to remember what my role in the clinic is the 3 S's. So I'm a speech pathologist, that starts with an S. I address speech, swallowing, and saliva. So it's pretty easy to remember what you would come to me for. What falls under speech, in this case, is the clarity of your speech, your voice, and communication in general. So that encompasses your comprehension of what someone else is saying, following conversations, and expressing your ideas and your thoughts. When it comes to Parkinson's, I meet people who mention that they're always repeating themselves, or that their family members have a hearing problem. So I generally kind of take a gentle approach to saying that with Parkinson's, there can be a change to your voice volume. You may find that in certain situations you have to repeat yourself, or that people are leaning forward a little bit more if they're being polite and not saying that they can't hear you, or that your speech is a little bit more mumbled. Sometimes in a group setting, it may be hard to follow conversations and catch what everyone is saying, or to express your thoughts and getting the right words out. Sometimes we all have those moments where you just can't remember that name of that person or that thing, but it happens a little bit more often, and that can be related to Parkinson's. Under swallowing, this includes coughing or choking a little bit more easily when you're having something to drink. Again, we all do this occasionally when we're talking or laughing, and then we take a sip and then we start coughing. But if this happens more regularly, and it normally happens gradually, this is a change that can be related to Parkinson's. It also applies to eating foods. You might find that your pills or certain foods that you eat take a little bit more effort to swallow, or you find that they're kind of getting caught moving down. And that's also something that I address and I assess. Saliva, too much saliva, not enough saliva. You can actually experience both when you have Parkinson's. Not both are caused by Parkinson's. The dryness can be caused by a side effect of your medication, and the extra saliva, well, that's something that I would discuss with you. So saliva management can actually affect your speech, and it can also affect your swallowing. So what do I do? You don't all see me that first session, but the team is pretty good at screening to determine if you need to come and meet me on a different day. And during that session, what I do is I assess your swallowing abilities, maybe have you bring some lunch in. We'll eat lunch together, except I won't eat, and I'll watch you eat and assess you. And then I also listen for your voice and do an assessment of the muscles that you use for speech, for your voice, for swallowing. And believe it or not, they're all sort of interconnected. I take into account saliva management and provide you with strategies with regards to that. Aside from that initial assessment, and perhaps a couple of follow-up sessions, which, as Orla said for her physiotherapy, are also generously covered by the Jeff and Diane Ross Movement Disorders Clinic, there are 2 specific services that I provide. One is a speech and voice therapy program, and the other one addresses face-to-face communication tools. So the speech and voice therapy program is a special program set aside where you would commit to 7 one-hour one-on-one sessions with me. This is for people who are having early difficulties being heard, being understood because their clarity of their speech is changing. It's not for everyone, so I use that initial assessment to determine if this is an option for you in the near future or maybe down the line, and I'll keep in touch with you to make sure things are okay so that we don't miss the window of opportunity for this program. This program is one-on-one therapy, and out in the community it can be quite expensive, but thanks to the Jeff and Diane Ross Movement Disorders Clinic, I'm able to provide it at a much more significantly subsidized cost, and I've had a lot of people of varying ages participate in and find great benefits. Some of them are here today. The other side is face-to-face communication tools. So your speech and your voice may change to the point where therapy isn't helping anymore or the strategies aren't helping. As Karen is authorized through the government to prescribe writing tools, I'm authorized to prescribe other devices that can help with your verbal output. So you can see pictures here of a few options. On the far left, your right is a voice amplifier. In the center is an alphabet board, and on the left is another communication tool that generates a voice. So you could put in a message and it will speak that message for you. I'm a huge proponent of your speech, your voice being heard. And if this becomes something that we go to, I would never say, okay, I don't want to hear your voice anymore, we're just going to switch to this. It's about the best for you and making you comfortable in communicating with others. So that's a little bit about what I do in a nutshell. And your communication is such a big part of your life. And no matter what you're managing with Parkinson's, to be able to express that to all of us, you need to have your speech and your voice or another way of getting that message across. And I'm happy to help with that. So I have the pleasure of introducing Vera. Vera holds her master's degree in clinical pharmacy from the Hebrew University of Jerusalem. She has years of experience in biomedical research, including computer modeling of chemotherapy. As a hospital pharmacist, Vera worked in cardiology, oncology, and geriatrics. She designed and conducted a study in cardiac catheterization in over 1,000 patients, which is published in the American Journal of Cardiology. In Canada, Vera worked for a pharmaceutical company in clinical studies for generic medications and led the scientific department for clinical trials. Currently, Vera works as a clinical pharmacist for nursing and retirement homes. Her passion is medication therapy for Parkinson's disease, and she currently consults with us for the Assistive Technology Clinic.
Thank you. Hello, everyone. Those who I know. Thank you for warm hello. It's a pleasure to see you. I'm truly honored to speak here today and take you through the role of the pharmacist in Parkinson. A lot has been said that the Parkinson care is not all about medications, but there is so much to know about medications, and there's so many of them. Probably the most important thing to know is to know how your medications work, and that would help you take them correctly, know what to expect, what to be alert to, and what to tell the doctor about. During our sessions, we would review with you each one of your Parkinson medications, how it works, why. It's probably one of the most painful questions. Why is it so important to take it so many times a day? And why the timing is so important. Even though you might not feel the symptoms return if you deviate, it's still crucial to stick to dosing times, and we will explain why. We will review all your other medications, be it prescription or over-the-counter medications you take just sometime, herbal medicine, basically every pharmaceutical product you might be using, because all of it too might have a crucial impact on your Parkinson therapy, and you might not even be aware of that. For example, some painkillers might increase your stomach sensitivity to Parkinson pills, or some medications might increase or decrease your appetite too much. Some might affect the bowel movement, and some might amplify the dizziness, and you might not connect those two together. We will also make sure that your schedule is working well for you. The whole idea is the medication therapy improves your life and doesn't disturb it. Though sometimes the dosing times prescribed by the doctor might not work quite well into your daily routine. You might be working, you might be supervising kids, it might not go along with your need for food, etc. We will work with you to make sure that it falls well into your daily routine. We will also try and make your schedule simpler, because some non-Parkinson medications could be taken together with Parkinson pills, so the time of the day, the amount of times to remember would decrease. But that, of course, needs a thorough review for possible interactions. We will make sure that it's actually working for you in practical settings. Do you need help remembering to take it on time? It might be very challenging remembering 5 or 6 times a day to take a pill on time. And if you don't, you might start suffering very shortly. We want to prevent that. And there's ways we can offer that you might not be well aware about. Did you know that there's pill boxes, ton of them posted online and sold online or in stores or different companies? They are various shape, various amount of times a day, various loudness of alarm, with electronic alarm that would go off every time that it's time to take your pill. And that's a substantial help that you can take off your mind that worry. You can carry them in your purse, put them in a pocket, some might stick to the keychain. It's amazing. There are blister packs that the pharmacy could prepare for you. These, for example, saved one of my clients who was going to a cottage, and in the cottage was very moist air, so he wouldn't be able to use the pillbox there and was stuck with the vials from the pharmacy again, and that was a disaster. So that's one of the ways we could let you know new things. There's a possibility for a cell phone alarm or a computer alarm that would again help you remind all those things. We would also go over with you what would you do if you forgot the dose. That's a tricky part because some pills might be chewed to help it pick up faster, while some pills should never be chewed or crushed, and that's crucial to know. We will also go over the side effects for you for each and every one of your medications, so you know what might appear, when to be alert to it. For example, with a new medication start, or with a dose change, or when some other medication might be started that might interact with it. We will tell you what to tell the doctor right away about. Some side effects could be managed on your own, and some need immediate attention from the doctor. We can explain to you how you can make it easier at home. We will spend some time on the most common side effects from Parkinson therapy. For example, for constipation, we will stop and explain which products are preferred to be used first, what should go then, and what to stay away from. And the alphabet would be that there always has to be a stool softener. Then there should be agents that retain water in your regimen. For example, like Laxaday or Restoralax, those products would retain water so the stool is softer. The next step might require, if that doesn't help you well enough, then the stimulant therapy might be required, but it's best to reserve on an as-needed basis. But in some scenario, for example, when you're on some painkillers, then the strategy will be totally different, and that needs to be highly individualized. We'll speak about the low blood pressure, review which ones of your medications might affect it, and how to manage that dizziness or lightheadedness you might experience. For example, did you know that compression stockings might be a magic relief sometimes? That moving your feet a little bit before getting up might improve it, and of course drinking a lot of fluids helps a lot. Oh, I need to go back. We will talk about sleep disturbances, whether they come from Parkinson or might be coming from some of your medications. We will explain everything about sleeping pills, whether it's something prescribed, something you're considering to buy, or offered by a friend. Never borrow a sleeping pill. Those are very tricky and require very thorough review of all your conditions and all your medications before trying it. As you probably caught from my presentation, there's a lot of those little things that make a big difference in medication therapy. And unfortunately, commonly available information might be too little, and it wouldn't be tailored to your specific case. And sometimes it might be hard to understand with all the medical terminology they continue to use. So during our sessions, we'll make sure that there's no more mystery left behind it and you get the best out of it. And that's a pharmacist in a nutshell. Now it is a pleasure and honor to introduce our next speaker, our psychologist, Dr. Naomi Greifer-Sapiria. Dr. Greifer-Sapiria completed her doctor's degree in clinical psychology in University of Western Ontario, and then her clinical residency training was at St. Joseph's Healthcare Hamilton. She specializes in treatment of anxiety and depression in chronically ill people, as well as in coping with chronic illness, pain, and stress. She's published in the areas of chronic pain and medical decision-making. She's also an amazing and warm person, which will open your heart to her right away. There she is.
Thank you, Vera, and hi, everybody. Hi. You know, as a psychologist, I know that a week after a presentation, you'll remember 2 to 3 things about the presentation, and I have a feeling that Sandy's lecture at the beginning is going to be one of them. So hopefully the second one is the benefits of our clinic. And I'm going to guess also that some of you in the crowd are wondering what a psychologist is doing on this panel. Because when you talk about your Parkinson's or you explain it to people, you focus on the physical symptoms, as most people do. Your pain, your fatigue, your tremor, all of these things. But most people don't talk about the stress that comes with illness. And I imagine that some of you may have been excellent managers of stress before, but adding another juggling ball of chronic illness can become very difficult. And why should you be stressed with a chronic illness? Well, you can tell me better than I can tell you, but a few things that people have suggested to me are things like all of a sudden scheduling your life around medical appointments, around medication dosing, around things that you never had to think about before, side effects of your medication. Are you going out during your on periods or your off periods? And as a result, some people find that their social activities are really less enjoyable. You worry about the embarrassment that might come with some of the symptoms, or you worry about your feelings of pain and fatigue when interacting with others. You also have to adjust to this new role, this new life. Perhaps you were never dependent on others in the same way that you have some have become now. And that can be a stress or a strain on relationships. And the neurological changes that are associated with Parkinson's actually result in decreased motivation. So if you didn't have any desire to exercise before, like me, I'm going to bet that you have no desire to exercise right now, right? The neurological changes also can result in mood changes. And I'm not talking about sort of the typical fluctuations that you might have had before, but 40% of patients actually experience what's called a clinical depression, where you're depressed, sad, down most of the day, nearly every day, more days than not. Hopefully this is not you, but if it is, there is help. And like I said, you know, Parkinson's doesn't only affect you, it also affects your relationships and your caregivers. And your caregivers are also adjusting to these new roles. All of these things add stress to your life. And why is it important to manage this stress? It's more important now than even before you had your diagnosis, and I'll tell you why. People who suffer from depression or chronic stress or poor motivation, this all impacts your ability to follow through on any of the recommendations any of my team members here have suggested to you. Like I said, if you have poor motivation, you're not going to want to exercise or follow through with your diet plans, or you might not even remember to do so if you have so many things going on. In addition, people with depression also experience greater distress from their illness, more medical complications. They have a faster progression of physical symptoms, greater cognitive decline, and overall poor quality of life. Because imagine if you're experiencing all these things, you're probably going to start thinking pretty negatively about everything and everyone around you. Now, some people say to me, well, how could I not think negatively about Parkinson's? It's an illness, and I didn't want to have this illness in the first place. But But I can tell you about two cases. Imagine that we have somebody named Joe and somebody named Mary, and they've both been recently diagnosed with Parkinson's. Mary might think to herself, my life is ruined and I have no control. If I had more time, I'd ask you, what do you think she's feeling in this particular situation? But I'll tell you, and I'm sure that you've guessed, she probably feels pretty scared and pretty depressed. And as a result, she begins to isolate herself from those around her and also from her rehab team. On the other hand, you might have someone like Joe who thinks, I wish this didn't happen, but I know that I can still have a meaningful life with Parkinson's. His emotions are probably quite different than Mary's. I see some nods in the crowd. He probably feels much more hopeful here. And as a result, he continues to be active and his physical symptoms also improve. Now you might say to me, nice try, Naomi, wishful thinking, how do I move from Mary to Joe? And I'm here to tell you that I can help. Okay? So as a psychologist, we offer something called cognitive behavioral therapy, where we explore the negative thoughts that you're experiencing and why you might be experiencing them. And we talk about how your thinking affects your behavior, like isolating yourself or going out and doing activities. And I offer practical strategies to reduce stress. Unfortunately, I don't have a magical cure, because if you had one, I would like to know it. But we offer real practical strategies that work with your life. We also try to contain your worries about the future, about the progression of your illness, which often plagues people. And we talk about we address your changing roles and relationships for you and for your caregiver. And does it work? Because I'm sure some of you are skeptical. The answer is yes. Cognitive behavioral therapy, there's been a lot of research to suggest that it's actually as effective as antidepressant medication, which you may have been prescribed by your family doctor or by a psychiatrist. And in fact, the effective therapy is longer lasting than going on medication. The longest study was probably only 2 years, but still at 2 years, gains were maintained. Also, getting rid of the depression and the stress in your life helps to minimize the faster progression of physical symptoms. It also reduces the risk of greater cognitive decline, and overall, it improves your quality of life. So how do you get to me? Because I want to emphasize that although it seems like a lofty goal, psychology can help you get there. That is a perfect segue into introducing Nicole Moncrief, who is our clinical administrator. And Nicole, she received her honors Bachelor of Science degree from the University of Toronto. She's responsible for handling all incoming referrals and inquiries regarding client intake processes to the clinic's interdisciplinary sessions. She's excited to be part of a unique team that offers such a high quality of care to clients while also empowering individuals with Parkinson's or other movement disorders to overcome daily challenges. Nicole.
Hi, everyone. Everyone's awake still. That's great. Okay. So now that you've had a brief introduction from our team in regards to what issues they address in our clinic and why, I'll be walking you through the process of what to expect when you come to the Jeff and Diane Ross Movement Disorders Clinic. So generally my role within the clinic is to provide a seamless process and be the line of communication between you guys and our clinicians here. So when you attend one of our sessions, you'll engage in one-on-one interactions with several members of our team for approximately half an hour each. I've listed the healthcare professionals who you will see in these sessions, which includes a physiotherapist, occupational therapist, dietitian, pharmacist, and Dr. Kleiner Fisman, along with the team, will see her clients in the morning sessions, whereas the rest of the team will see other clients who are not of Dr. Kleiner Fisman in the afternoon sessions. These half-an-hour time slots with each healthcare professional provide our team the opportunity to discuss with you what issues need to be addressed and also give you the opportunity to ask any questions you need answered. At the end of the appointment, you'll receive a treatment plan tailored to your individual needs, which identify issues and recommendations to overcome these challenges. After seeing our team, you may be referred to other team members, such as the speech-language pathologist and our clinical health psychologist, as well as other programs within the assistive technology clinic. In terms of length of time, the sessions last approximately 2 to 2.5 hours. Since it can be a bit lengthy, we suggest you bring a snack or lunch, and as well as your medications, of course. Sometimes there may be delays that may be out of our control, but we do our best to stay within this 2.5-hour window. So, in order to take part in our sessions, there must be a confirmed diagnosis of Parkinson's and/or other related movement disorder. People often ask me if these sessions are only geared towards our clients. However, we request that caregivers, so family members, friends, or spouses attend, since helpful information will be reviewed with them as well. As Orla stated earlier, caregivers are a part of the team, and being part of the team means that we listen to what caregivers have to say as well. And of course, it also doesn't hurt to have an extra set of ears and eyes, as it is a lot of information to take in that amount of time. So basically, the next steps in making an appointment to see our team is pretty simple. You just have to go to your family doctor and have them complete one of our referral forms, which I'll go over with you briefly on where you can find that, and have them fax it to our clinic along with the most recent consult notes from your neurologist. And then shortly after, once that documentation is received and processed, you'll be contacted to schedule an appointment. So if you go to our website, www.assistivetechnologyclinic.ca, there'll be a set of tabs at the top of the screen, and what you can do is click on the referrals tab, and under the referrals, you'll see Jeff and Diane Ross Movement Disorders Clinic, and what you can do is click on that, and it will, what will pop up is a printable referral form. So you can let your family doctor know this, and they can actually retrieve it themselves off of the web.
What would be the waiting period? I'm sure there's, I don't know if you could comment, everyone, what would be the waiting period?
Okay, the waiting period to see our team members alone, if that's what you're referring to, so that excludes Dr. Kleiner Fisman. Her waiting time is a bit lengthier, but for us right now we're booking into the end of July, so it's not too far off. So this is just our home page here, a part of it. So as I said, referrals is at the top. You just click on that. And then click on Jeff and Diane Ross Movement Disorders Clinic, and the referral form will come up. So just to conclude our presentation, we'd like to thank Jeff and Diane Ross, as none of this would be possible without their generosity. Thank you to Sandy Jones and the Parkinson's Society for inviting us to host this wonderful event. And of course, to everyone here in attendance, we thank you for taking the time, coming here and seeing us speak. We'll see or hear your questions in the next segment. Look forward to it. Thank you.
The good news is that earlier, Nicole, who was the last speaker, the administrator of the clinic, the Movement Disorder Clinic, said that you could go online to get the referral form if you would like to attend the Baycrest Movement Disorder Clinic that you've heard so eloquently about tonight. The good news is that I've got the forms with me. I wasn't going to give them to you until I saw whether you were going to be well behaved. But you've really done me proud. Thank you so much. This is great. So I have them up here. They're sitting beside Dr. Kleiner Fisman. I'm just going to put them down on the stage at the end of the evening. If you would like to get one rather than get one from the computer, then please come and help yourselves. But you do have to do what Nicole said. You have to be referred by the family doctor. You can take this form to him or her, get them to fill it in. They do need the records of your most recent neurological consult, etc., and also a list of the current medications that you're taking. Okay? All right. Now, the even better news is that we're going to be here till midnight, so get really comfy. I think I have 4,563 questions, okay? But before we get there, I promised that we were going to do the draw for the lovely prize tonight. So I'm going to ask Dr. Oh, by the way, in case I didn't grow during the intermission, but the videographer has kindly provided me with a box. Now, I've been told I'm always on my soapbox. Now I've got one. It's very exciting. So now you can see me. Instead of me, apparently I was just kind of level with the podium. Being horizontally kind of challenged. That's the word. Thank you for that word finding problem that I was having. you know, here I am. All right, so Galit, would you please draw the drum roll, please? Somebody, anybody, come on. Thank you so much. Okay, so the winner of this evening's prize is Deirdre Ballack. She here? I saw her earlier. She's still, oh, there you are. Yay! What the heck did I do with them? Quick, take it before I forget the whole thing. Here you go. Okay, no problem. Onward and upward. So the way this is going to work is I'm going to ask the question, and whoever on the panel feels that this question belongs to them is going to take ownership of it, and they will answer the question. They all have individual mics, so they will be able, which I think are working. Are they? Are you all working?
Yep.
You're all okay. Good. We're all good to go. So whoever is going to take these questions and answer them as members of the panel. Okay, off we go. First question: how can Tai Chi benefit those with Parkinson's disease?
That would be me. Will I stand or I can stay sitting? Tai Chi can actually help with a lot of coordination, balance, movement. It's also very social, so it can actually be a very good de-stressor as well. I know a lot of people struggle to get into a normal exercise group, but it is important to actually get doing something. Tai Chi is very, very good, and it is very calming as well. So if you are quite high stressed and highly strung, Tai Chi can be really helpful.
Okay. You know what? I know these guys are going to do a really good job, but I don't think with all these questions we have time for the claps. So just, you know, let's just clap at the end. Are you good with that? Okay? No clapping, except for me. All right, off we go. I hear Parkinson's affects all the muscles in the body. Does this include the heart? And if so, how?
I guess I should probably answer.
Well, that would be a doctor question. Yeah. Good for you. That was very... If I didn't love you so much, I'd smack you. Okay.
Well, the truth is that Parkinson's doesn't affect muscles per se. The muscles are listening to the information from the brain, so it affects the brain. And the brain gives information, and the muscles themselves, from a pathological point of view, are perfectly normal. There can be some abnormalities in what we call the autonomic function, so the involuntary nervous system. So you can find the Lewy bodies, which are the protein inclusions in the cells, not just in the brain, but in also peripheral nervous system. So in fact, this can affect the heart, and it may be one of the reasons why people have a hard time maintaining their blood pressure properly. So when they stand up, their blood pressure may drop. That's probably one of the most common ways that it affects the heart. It doesn't otherwise have any impact on the heart.
Okay. Do different sources of proteins, for example, meat and fish, have various effects on the body?
That's mine. So there are different types of protein, as we all know. There's animal sources of protein, which are from, which would include poultry and fish and eggs, and they have the highest amounts of protein, and also egg are also in that group. And then there are some people who think that non-protein sources, such as protein found in legumes and vegetables, may affect a person differently. But it really is individualized, and everybody's different with the effects of the protein on the L-DOPA. So I always say try the animal versus the non-animal protein. If you're not having an effect with one versus the other, it's fine to have both of them. But every food has a different amount of protein in it, and you can find it. I have a handout that I give to people that shows you exactly how much protein is in a food, and non-animal sources definitely have less sources of protein, less amount of protein than animal sources, but they all contain protein, and it's the protein, it's the actual protein that is the effect. So regardless of how much it is, or it will have an effect.
What about vitamins? You recommend vitamins or?
Are we taking questions?
No. Okay. Yeah, go ahead.
It depends what vitamins and for what purposes. Specifically for Parkinson's, you don't need to take vitamins if you have a healthy diet. But if you, for example, are osteoporotic, you may want to take vitamin D. So vitamins are good for general health for very specific things, but not specifically for Parkinson's.
Okay. When a caregiver is having a hard time with her spouse's depression and the spouse denies his depression, what can I do?
That's a good question. There's lots that can be done. Depression affects you both cognitively and also from a behavioral standpoint. So if your spouse is not willing to engage sort of cognitively about the thinking about depression, you might want to go from a more behavioral angle. So find something that they once enjoyed doing and break it down into very small steps. So for a non-depressed person, something like going to a movie, for example, doesn't seem all that overwhelming. And we often encourage people, because we want to encourage them, you know, come on, let's just do it. But to someone with depression, that can seem very overwhelming. And there's a lot of steps that are involved in getting them there. So for example, getting the newspaper, looking at, or online, looking at what movie you want, and then actually buying a ticket, and then getting in a car, and then going to a theater, and then sitting down in your seat. So perhaps the first step is actually just getting someone to the point where the newspaper is open to choose the movie in the first place. So break it down into really small steps. Over time, that will encourage people's confidence, and slowly they'll start to be more motivated to engage in other activities as well. That's a simple thing, not so simple, but it's a small thing that you can do to try to encourage people to get to the point where then they're then willing to start having discussions about their depression and possibly seeking some help.
Okay, this is for you, Nicole. What advice do you have for Parkinson's patients concerning coffee?
Well, everybody can consume coffee as long as you don't consume a lot of coffee. So I always say it's okay to have 1 to 2 cups of coffee a day. There's no problems with it. If you start drinking more coffee than, let's say, 2 cups a day, there are things in coffee that could cause your blood pressure to change and different effects. But having 1 to 2 cups of coffee, it's fine.
Maybe I can just add a little bit to that, because I wonder if maybe people are asking about coffee because there's some studies that suggest that maybe caffeine is protective with respect to Parkinson's. And I don't think there's good data out there to suggest that you should all go be drinking 6 cups of coffee a day. There may be some theoretical relationship between caffeine and Parkinson's, but exactly what that relationship is hasn't really been defined. And there's really no clear indications at this point that caffeine is some kind of a therapeutic regimen. So people should drink coffee the way they would usually drink coffee without any consideration about what its impact is on Parkinson's. The other issue with regards to coffee is that people often have problems related to sleep. So if you drink coffee later in the day, that can impact your ability to fall asleep. Also, if people are already having issues related to low blood pressure when they stand up, coffee is a diuretic, so it will cause them to actually get dehydrated. And one of the strategies to improving dizziness when standing up is to actually drink lots of water and salt. I often prescribe the chicken soup strategy. So drinking coffee is a way of actually reducing blood and fluid volume in the body. So one has to keep that in mind when drinking caffeinated beverages.
Also, coffee is considered an antioxidant, correct? Antioxidant? Yes, so therefore generally coffee is good for you.
Okay, this question's for Vera.
If I may add to the coffee question,
Oh.
I believe Nicole would agree with me that coffee in quantities more than a couple of cups a day would drain the calcium out of your bones and actually predispose you to osteoporosis. So they recommend you take an extra cup of milk a day per every extra cup of coffee a day. So I wouldn't go that way.
So you were very team-oriented.
I was going to say, we're going to get you drinking no matter what. Okay, this is a question for you, Vera. For someone who cannot tolerate levodopa, or it doesn't seem to help, is there another medication that could minimize tremors?
There are a few medications that work on tremors, and some of them are not generally used for Parkinson. They can be tried. However, with caution, and Dr. Fisman would agree with me, the proper review of your other conditions and other medications, as they might affect the heart and blood pressure. And I'll pass it on further to Dr. Fisman.
So the question is regarding other medications to control tremor?
Yeah.
Other than levodopa?
Yes.
Yeah. There are all kinds of medications for use in Parkinson's. There are all kinds of medications that are used in Parkinson's to address symptoms of Parkinson's. If it is truly a Parkinson's tremor, the dopamine medications often are effective, but sometimes we're not that successful for various different reasons. Sometimes there's side effects that limit the ability to increase the dose to a therapeutic dose. So there's no one answer. All you have to do is take X and your tremor will be controlled. It depends on who you are. It depends on what your response is to every medication. It depends on what your side effect profile and tolerance status is. So it's not possible to answer that question in general. In general, there are numerous medications that we use in our armamentarium to address symptoms of Parkinson's. And for every person, we choose the combination in a different way depending on what their situation is.
If someone has had Parkinson's for 10 years or more and is 80 years of age, is it still possible for them to benefit from the services provided at your clinic?
Can I answer that? I would
Pick me, you can.
I would say that is a perfect person to benefit from the services of our clinic. In fact, our clinic really, we do have what we call a young onset Parkinson's clinic, and that's partially because Baycrest limits the age of people I can see because it's a geriatric center. So we have that's not really a collaborative effort. For the younger people that are under 65, we see them at the ATC clinic, at the Movement Disorder Clinic, and we provide services for them. But really the majority of the people that we see are geriatric patients, and they are a much more complex group of people than a person who's 50 years old. A person who's 80 years old will have different considerations, different other medical conditions, other social situations, other medications that may take, the other priorities in their life, and we still have to consider their needs. Just because they may not be able to take high doses of certain medication doesn't mean that there's nothing we can do for them. In fact, our services are particularly well suited for this type of clientele.
How much time should elapse before eating after taking levodopa? Half an hour or an hour? I'm confused. I am confused, but that's what the question actually says.
Okay, well,
in our clinic, we go by the half an hour rule, although I often hear people come and say, but I was told an hour. We say a half an hour, and Dr. Fisman will probably elaborate on that.
Well, you know what, there's no set rule. It kind of depends on, the point is that you don't want protein to be in the stomach at the same time as the levodopa. As Nicole had explained in her presentation, protein and levodopa compete for the same receptor to get into the bloodstream and then get to the brain. So if protein is in the stomach at the same time as the levodopa, it's not as effectively absorbed. So the whole point is it's not really a matter of, is it 15 minutes, is it 20 minutes, is it half an hour? It's however long it is for the medicine to get into the blood and out of the stomach, and then the protein can come along. So it's probably somewhere between half an hour to an hour. And I think that you're safe probably within half an hour, but it doesn't really matter. Just the whole idea is that we try and space out protein from the time that we are taking our medications. And then I would say it's about 2 hours. It takes about 2 hours to digest food. People with Parkinson's may not digest as quickly because everything slows down, including digestive muscles. And so we try and at least give a 2-hour window after taking levodopa before we suggest people eat again. Now, this can be kind of complicated for people because if you're taking medications every 3 hours or less, then there may not even be that time period that allows you an empty protein stomach and taking medications. In which case, what we try and suggest is a protein redistribution diet. And what that means is that we try and reduce, in general, the amount of protein that we eat during the day such that even if it's not sort of half an hour and an hour or 2 hours after, it's just in general during the day we eat relatively low protein, and then in the evening we make it up and eat a higher protein meal. The idea is that you're still getting the same amount of protein every day, you're still maintaining your daily nutritional requirements, but during the day when you are hopefully most mobile, you are limiting the amount of protein you eat so that your medications work the best. In the evening, when a lot of people are watching TV or maybe more sedentary, it may not be as important to have the same strong benefits of the medication, and so it's okay at that time to have a higher protein meal.
What costs are involved to attend your clinic?
Well, in terms of our session, of course, that I explained earlier, it is free. So there is no cost at all to come and see our team members. However, additional programs at the Assistive Technology Clinic, there may be some other fees involved.
Usually just administrative fees. I mean, this is a heavily subsidized program.
Yeah.
Every allied health professional provides some sessions that are free. However, if the programs become more extensive, then we have to charge a small, really a nominal fee just to allow for administrative work and so forth. But most of the programs are subsidized.
I have a movement disorder specialist, but I would like to participate in the Baycrest program. Is that possible? Would I be limited in any way?
No, you wouldn't. If you already have a movement disorder neurologist, right, that's what the question stated. So you can see all our team members here. The only thing is you wouldn't be seeing Dr. Kleiner Fisman.
Well, it's up to you.
Per se, but
I mean, you have access to the team if you want, or if you want to have a medical assessment as well, it's the same process. You simply get a referral. That's it.
Yeah.
What is the latest research on the effect of Parkinson's on eyesight? I don't like Dr. Kleiner Fisman.
I can't say that I'm specifically aware of Parkinson's disease and eyesight. There isn't any there's nothing that's sort of on my radar that that eyesight is specifically affected by Parkinson's. There are other neurodegenerative conditions that can mimic Parkinson's that impact eye movements, but Parkinson's per se doesn't necessarily affect vision. There's plenty of other eye pathologies that, as people age, that can affect vision, but Parkinson's itself, usually not.
Okay. How do you help someone who is recently diagnosed and is totally consumed by fear and confusion, who has isolated himself from everyone else and accepts no help from his family or professionals?
Well, it's hard to answer that in sort of a general way, but to try to understand that from their perspective, fear of the unknown, uncertainty in general, it can be a very scary thing. In fact, the source of most people's anxiety, not just for having an illness, but in general, is sort of fear of not knowing what's going to be. So perhaps discussing those fears with them if they're willing. Otherwise, support groups where they see other people who have the same condition but further along might alleviate some of the fears. And you can also, if they're not, I mean, the best thing to do is to refer them to a professional, but if they're not willing, then I would say to at least allow them a safe place to express those fears. Some people say that there is evidence to suggest that actually something called worry time, where you actually are only allowed to worry during a specific hour of the day. And it sounds crazy. And when I learned about it, I also thought, this is crazy. How can you do that? But it actually, there's research to suggest that that works. So during 5 to 6 p.m., you can worry during that time. And otherwise, please live your life. And in fact, during the day, you say, if a worry thought comes into your head, because you can't stop thoughts from coming into your head, unfortunately, but you can say, I'm going to worry about this during my worry time. And it works. So I accept your laughter, because to me it seemed crazy, but it works. So that's another strategy that you can try as well.
Thank you. I'm going to try that right away. Okay, this is my worry time. Okay. I have an appointment at the ATC clinic, but it does not include the physiotherapist or seeing the neurologist, and why. I only am going to be seeing the occupational therapist, the dietitian, and the pharmacist.
She just had a baby.
That's the truth.
But I've just had a baby who's just 2 months old, so I'm on mat leave. So that's why you're not seeing the physiotherapist at this time. But
Would you just get back to work? What's your problem?
Pitching in for
Karen
Orla.
is well able to refer you on to the other sort of programs that we actually have available. There are other physiotherapists, and we have a kinesiologist as well who can actually run the programs, so you will actually be seen and your issues will be identified, and we can actually get you into the other programs.
And I'll actually be looking at all of your exercises, your exercise regime. We can try polling, we can try lots of different exercises and discuss that on the visit. So not to worry, we'll address those issues.
I would like to know the rate and progression of Parkinson's. At this point in time, I have just been diagnosed, and I do not have many visible symptoms. What can I expect, or is it different in every case? And is that why we have to come to your clinic?
I actually...
That was a good answer.
You don't have to come to our clinic, but I'll tell you the philosophy, my philosophy, and I think I share it with the team, is that we would not be doing you a proper service by predicting what's going to happen. Every person is different, and I have some patients that come to see me that have had Parkinson's for 25 or 30 years, and they still come to see me, and they're walking, or there may be an alternate way of coming to see me, but they're still coming to see me. Everybody has a completely different experience, and it's not fair to make any predictions, and it also, I mean, it's important to look at the big picture, and we all think about what may be 5 to 10 years from now, and we all have to plan our life, knowing that time passes and different things can happen. But it's also important not to focus on what may be in 5 years, because to any of us, anything could happen in 5 years. And what's important is, how are we going to live our life today and make the most of it today? And how are we going to live it tomorrow? And how are we going to live it next week? And how are we going to live it in 6 months from now? And I think that those kind of things we can absolutely help you with. And then what we can say is, I don't know what's going to be in 5 years, but we'll be here, and we'll be here to support you through whatever it is that we need to do. So I think that's really all one can say in general in life.
And if I can add, and it sort of speaks to the question before too, sometimes the best thing to say to yourself is, I might not know what's going to happen in the future, but what do I know right now? And so it's hard, we can never predict, like Galit was saying, we can never predict what's going to happen, but you do have certain tools at your disposal right now, and sometimes that helps manage the uncertainty that comes with what's going to come next.
Is there anything that could reduce or eliminate facial dyskinesia and distortions?
Absolutely. That's related to appropriate decisions regarding how to use the medications. So yeah, there's a lot that can be done, but there's no general answer. The facial dyskinesias that can occur are usually a manifestation of both the stage of Parkinson's as well as the medication that's being used. So somebody without Parkinson's, regardless of how much medication they take, they're not going to get dyskinesia. But with Parkinson's, at a certain point, there may be the side effects of involuntary movements, but these can be managed either with alternate medications, reduction in dose, or different way of taking the medication. So that becomes one of the fairly kind of complex things that we do in the clinic, and that's why a lot of the time the evaluations take a bit of time to try and figure out when are these involuntary movements happening, are they a peak effect, are they a low effect, how much are they bothersome, in what way are they interfering, what is the downside to reducing medication, and that sort of stuff. So we really consider very carefully the pharmacologic management.
If you are accepted into the program, A, do they follow your condition and progress? And B, if yes, for how long?
Nobody has to take a test to come into the program. Everybody is accepted into the program. It's just an issue of resource in terms of a waiting list, because at this point, unfortunately, I'm the only doctor there. If we can have a second doctor, then the waiting list would be shorter. We follow patients as long as they need to be followed. There is no sort of finite amount of time.
And we do see for follow-up appointments after the initial assessment.
Right.
And then we will do ongoing follow-up.
Absolutely,
So
and the follow-up is not just with one of us, it's with all of us.
And you are always free to contact us via email, via telephone. Our ears and our emails are open to any of your questions.
And we'll provide you with that contact information at your first visit.
This next first part is an actual comment. It says, "We would like to extend a huge thank you to this wonderful panel." But, there's a but. And also, Sandy and Nassim and Parkinson's Society Central and Northern Ontario for putting together this event. Yes! We did a good job. Okay, sorry. Question. If accepted into the movement disorder clinic, so there's something about what you guys did that made people think that, it's like, pick me, pick me. Okay, all right. Do patients continue to, this is a similar question, continue to see their movement disorder specialist, if they have one, and in addition to the other specialists that the clinic, or will the clinic take over all the primary care, basically?
You mean primary care of the movement disorder?
I think,
So if
yes.
they have
Yes.
a different neurologist.
Oh, you mean you can't take over everybody's complete primary care? What's wrong? Okay.
We are, basically it's the person's preference, whichever doctor they want to see, they're welcome to see. It's your choice. You can either see just the team and continue with your movement disorder doctor, or you can see all of us. You probably don't need 2 movement disorder doctors. That's probably not a good use of resources, but it's your choice as to who you want to see.
What if we think we're managing? Should we bother your team just to see if there are possibilities for improvement?
We will never feel like you are bothering us. That's what we're here for. We're here to listen to what your issues are or concerns, or just to talk. If there's something that you may or may not want to bring up, we can bring it up. It's totally up to you. So there are never any, silly questions or things that you feel like, oh, that's not important. If it's important to you, it's important to us.
And also, if I can add that with some of these things, even if you're not having any trouble now, it may be good for you to know what you really have available to you. I mean, you got a glimpse of it now, but especially for us to have a pulse on you, like I said before, if something were to change. And so you could contact us at that point.
And if I may add as well, from the pharmacist perspective, we sometimes find surprising things, and the person would come and think they're okay, and we would find out something. I'll say, "Oh, that's so easy. I didn't know that before. Why didn't I know it all those years? My life could have been so much easier." For example, by going back to the eyesight question, it might be not a direct result of Parkinson's, but it might be a result of Parkinson's medications. Some of them would affect the eyes. And there's just one certain group that affects the eyes the most, or you might just blink less frequently because of the Parkinson decreased muscle tone, and then the eye moisturizer would provide a great help, and you would never probably know. So you're very welcome to come see us.
My husband used to be a patient of Dr. Gutman. Because of a lack of funding from the Ontario government, he has since referred us, or him, to the movement disorder clinic. He referred, wait a minute, he has to close part of his movement disorder clinic, I beg your pardon. He referred my husband to Dr. Kleiner Fisman. When will we know if he has been accepted?
Everybody's accepted. It's just a matter of time, that's all.
How much time?
We don't know.
I mean, we are getting a lot of referrals as a result of the closing of Dr. Gutman's movement disorders clinic in Markham. So as Dr. Kleiner Fisman mentioned, it is a lot of time. We don't know who you are, and I don't have a list in front of me to tell you how long it will be, but of course, sooner rather than later, you will be informed about your appointment.
Is swelling of the foot and leg on the side of my Parkinson's tremor a side effect of my medication? I have Parkinson's only on my right side.
You know, it's not fair to answer that question because I would have to do a complete assessment to look at all the different factors that cause people to have a swollen leg. Typically, having a swollen leg because you have Parkinson's, swollen legs as part of Parkinson's is not a typical symptom. You can have swollen legs from medications you take for Parkinson's. In fact, some of the dopamine agonists like Mirapex or Rapinirole, 20% of people get swollen feet as a result of that. But there's many other causes for swollen feet, so I can't really answer it. Specifically related to Parkinson's, your feet should not swell.
Do you use computer facilities to enable assessments and program delivery without face-to-face meetings? For example, Skype, so that a patient would not have to travel to Baycrest?
We haven't to date done that from our clinic, but I think there's...
We certainly have in some of our other clinics, ALS, MS clinics. Certainly nothing substitutes for face-to-face and meeting you in person. And we're able to do a much more thorough examination, and I think certainly Lily will attest to that. The ideal in terms of medical management and interdisciplinary team management is meeting you in person, and then we really get a good sense of who you are and what your issues are. But that's not to say that follow-up could be something we would look at in the future from a technology or computer access.
I believe this question is about what the process is for ongoing monitoring after the initial assessment.
Well, it depends on the person and what they need. So usually what happens is if we initiate new medications at the time of the initial assessment, a few weeks later, like 3 or 4, I will see people again in follow-up to see the impact of the medication, and that's usually in context of the interdisciplinary session. Depending on what the status is of medications at that time, we decide on when we need to see people again. There is no set time. It's not like everybody comes back in 6 months. People come back whenever they need to come back. That's generally our rule.
Okay. There hasn't been any mention of other medical conditions in addition to Parkinson's. I don't understand that question quite or what it's referencing, but that's the question.
Well, maybe you're thinking about Parkinsonisms that aren't necessarily what we call idiopathic Parkinson's disease. So some of you may know that Parkinson's disease is a clinical diagnosis. It's not something that if we look at an MRI or if we do a blood test, we can say somebody has Parkinson's. Parkinson's is based on a clinical assessment. Now, there are other conditions that may mimic Parkinson's that aren't Parkinson's disease. Parkinson's disease is something that you can only prove if you were to look at the brain under the microscope, which we don't do in life. So in life, people can only have either possible or probable Parkinson's. But we know clinically that there are some very typical things that we see in Parkinson's disease, that entity that we recognize under the microscope. But there are other neurodegenerative conditions that can mimic Parkinson's. They have some subtle atypical features. Again, there's no lab test to prove what those are. We accept everyone that has a diagnosis of Parkinsonism, whether or not it's Parkinson's disease. It can be due to other causes like progressive supranuclear palsy, multiple system atrophy, corticobasal syndrome, vascular Parkinson's. There's all kinds of other things that aren't Parkinson's disease, but still result in problems related to movements and affecting the nervous system to function optimally. So we see everybody in that regard. I don't know if that answered it.
How do we find out about polling classes if not a member of your clinic?
You can go onto our website, so www.assistivetechnologyclinic.ca, and there is a referral form for polling classes as well. Certainly, if you're coming through the clinic, I'm happy to talk to you about that. We certainly could try them that same day as well. So a couple of ways of doing that.
But I think there's also, even outside of our clinic, you can just Google polling.
Urbanpolling.com is a big sort of company that actually runs classes in and around GTA. So if you did not want to do it just through our clinic, there are definitely other companies that actually do polling. Nordic polling is sort of pole walking. We just use the one sort of urban polling, but Nordic walking is exactly the same, so it has the same principles. Yeah.
Good luck with this one. How easy is it to find a Parkinson's specialist, and how long would it take?
That's a real problem.
You just found her.
There's not very many people in Ontario that are movement disorder specialists. There's a group at the Toronto Western Hospital. That's obviously the biggest group. And then there's basically us. There's a person downtown that's a private consultant, and Dr. Gutman's group that I'm not exactly sure what is going to be the disposition of Dr. Gutman's practice. So it's a real problem. I mentioned to some of you that last year I had the opportunity to go to Ottawa and testify in front of the Committee on Health regarding a roadmap for the future in recognition that illnesses such as Parkinson's disease are beginning to cost society a lot of money. That's what governments are interested in terms of what's going to be the burden on society. And so I talked to them about our clinic and about our model, and everybody seemed to recognize that it made sense and it made financial sense. But what happens between them hearing that and writing it in their report and it actually devoting resources to having more specialists in this regard, I don't know. I think it has to be sort of from a grassroots level. People have to organize and put pressure on government to devote resources to these problems.
How can we get better community care? How can we get therapy paid for by OHIP, for example? And the last part of this question is, what is faux walking?
What?
F-A-U-X, faux walking.
Can't say I've ever heard of it.
Is the person who, although I said please nothing from the audience, is the person who asked this question in the audience? Faux walking? The reason I'm asking is, I mean, every question is really important, and I know the panel really wants to address all of your questions. I'm wondering if there's any chance that you heard pole walking and thought you heard faux walking. Is there any chance of that? I honestly don't know. But if the person who asked the question isn't here, I think we can't answer that. But about getting better community care and therapy paid for by OHIP for those with neurology issues.
Well, there is some services provided through the community care access centers, like I said, in terms of you can have an occupational therapist go into your home and do a full home safety assessment, look at how you're managing your daily activities, those types of things actually in your home. A physiotherapist can go in and look how you're managing in terms of mobility, if you're having issues with climbing stairs, those types of things, and looking at community mobility. So some of those things are available, but they, are, time limited. It's kind of based on what your needs are at that time, or if your needs change, then we can certainly refer you back to some of those things. I hope that answers the question.
I hope so. I'm currently being treated at Sunnybrook Hospital. Can I attend your programs?
Everyone can attend.
If you don't get the message now, you never will. Everybody's welcome. Okay, that's actually the last question, but it's not the last for me to do tonight. I tried to be as reasonably organized as I could, but I actually forgot to get the gifts up here. So can you just bear with me for a second? Oh, are they? Oh my goodness, my colleagues have taken care of me knowing this memory. Okay, hang on. So we have one gift for your clinic that I hope you will be able to put up and enjoy as a representative. I'm really going to try not to cry, but it's going to be really hard. Of how grateful we are for all of your time this evening. I'm sorry, I don't seem to be able to look at you. Okay, I'm just going to look at you. I don't care if you can't hear. Okay. Thank you, each and every one of you, for giving up so much of your very precious time, for the preparation that went into your presentations tonight, and for everything that you're doing on behalf of people with Parkinson's to really help them to be the best they can be. I love you guys, and I'm so proud of everything that you're doing, and I'm so grateful for everything. Thank you so much. Please give them a warm thank you.